Dr. Nam, Dr. Park, and Mike Gibson joining you live from ESC 2024, and we're talking about the EPIC-CAD trial, a trial of Edoxaban in patients with stable CAD and atrial fibrillation. Very excited to hear what you have to say, having done the Pioneer trial. So talk to us a little bit about what you did and what you found.
First of all, thank you so much for inviting us to this clinical trial results. It's my great pleasure to report our primary results of EPIC-CAD in this interview. Before we start, a little bit of background information is that in a significant number of patients with coronary artery disease, they have concomitant atrial fibrillation. And the management of these patients is challenging because for efficacy alone, the combination of anticoagulant and antiplatelet will be best. However, if we consider the risk of bleeding, the OAC monotherapy could be a safer option. And the balance between the safety and efficacy is a critical point in the management of this patient. So current guideline indicates that for patients with stable coronary artery disease, they recommend a monotherapy of OAC alone. And this is a class 1 indication. However, the scientific evidence to support this guideline is not sufficient yet. So EPIC-CAD is an investigator-initiated multi-center randomized clinical trial to compare the efficacy and safety of the two treatment regimen of Edoxaban monotherapy versus Edoxaban plus single antiplatelet to a therapy group.
Fascinating. And what kind of dose of Edoxaban did you use? You know, I know in your part of the world, sometimes you go with lower doses of Edoxaban instead of our doses. And then when you talk about antiplatelet therapy, did you use aspirin monotherapy or thienopyridine monotherapy?
Yes, so in our trial is compared to in the prior fire trial, is one of the favorable fire trial used the local approved dose and the reduced dose. In our trial, one of the advantage of EPIC-CAD trial, we use the standard dose Edoxaban, 60 milligram, the once daily, and in patients with dose reduction criteria, we prescribe the 30 milligram Edoxaban. Also, single antiplatelet therapy, and we used the aspirin or clopidogrel, but the final choice was discretion of treating physician.
I see. So this was not 15, any 15. This was 30 or 60. Great. And how many patients were enrolled? And what was it non-inferiority, superiority?
Yes, our trial was a superior design with primary outcome of composite of safety and efficacy outcomes. And our clinical outcome was a composite of all-cause mortality, myocardial infarction, stroke, systemic embolism, and unplanned revascularization, plus major bleeding and clinical relevant non-major bleeding, all the composite of those outcomes. And our primary outcome after 1 year after randomization, the occurrence of the primary outcome in the dual therapy group, it was 16.2%. And in the monotherapy group, it was 6.8%. And the hazard ratio was 0.44, with a statistically significant difference between the two groups. And
so you actually met your superiority criteria.
Absolutely.
And what about on the efficacy, death, MI, ischemic stroke, and revasc. When you look at efficacy alone, how did you do?
Yes, so and I think as you commented, efficacy outcome is the reason why the mortality was significantly lower in the rivaroxaban monotherapy group of FIRE trial. And by contrast, in our trial, we didn't find any the efficacy outcome. The mortality is very similar in the 15-2 group, in the edoxaban monotherapy group, 0.6%, and the dual the therapy groups 0.7%. Also, major ischemic endpoint was occurred in the 1.6% in the edoxaban monotherapy and the 1.8% in the dual antiplatelet therapy. We didn't find any the efficacy outcome between the two groups.
So most of the difference was driven by a reduction in bleeding.
Absolutely.
Was it bleeding or clinically relevant non-major bleeding?
So in our trial is we defined by ISTH definition. Also, we defined the TIMI and BOC definition, and the primary bleeding event was assessed ISTH bleeding, and the major bleeding event we defined the major or clinically relevant non-major bleeding, and that was also significantly lower with the edoxaban monotherapy group. Also, each outcome. Major bleeding was significantly lower, as well as non-major or clinical relevant bleeding was also substantially lower with the edoxaban monotherapy group.
And was that true for both aspirin and clopidogrel? How many got clopidogrel? How many got aspirin?
Yes, so in our trial, aspirin was used 62% and clopidogrel was used 38%. We performed the pre-defined specified subgroup analysis, and overall finding in terms of safety and efficacy outcome was consistent in the irrespective of aspirin or clopidogrel, appropriate or inappropriate dosing of edoxaban, and any clinical factor, and the overall finding was consistent.
Interesting. So does this change practice?
Okay, Professor Nam.
Dukwoo is smiling. I think that means he thinks it does. Yeah.
Yes, I'm not sure of the other situation of other countries, but at least in Korea, the adherence to antiplatelet agent among interventional cardiologists is very strong. It's very strong obsession to antiplatelet therapy. So many of the interventional cardiologists still want to continue the aspirin or clopidogrel on top of the oral anticoagulant. So with the result of our study, I believe this is a strong support for the current guideline of monotherapy alone. So I hope this our result could change the practice pattern of the treating physicians, particularly interventional cardiologists.
Thank you.
So, and yeah, I think in the clinical viewpoint and looking at the clinical trial available, and given that prior available trial always alone and the FIRE trial, both trial was premature terminated. Also, a FIRE trial did not use global dosing. So I think our EPIC-CAD trial provide additional new evidence in the appropriate chronic long-term therapy and the inpatient AFib and stable CAD.
Dr. I just want to clarify one point. Did people get no aspirin after the procedure in the one arm, or did they get a week or a month, or is this no aspirin or no antiplatelet?
Yes, so our targeting is just the stable coronary artery disease and the ACS population beyond 1 year, chronic coronary syndrome in the beyond 6 months after revascularization. Also, we included 30% is medical therapy alone. So, and edoxaban monotherapy, absolutely edoxaban monotherapy keeping. And another group, the combination single antiplatelet aspirin used 6%, clopidogrel is 70%, and beyond the trial the duration, and the maintenance therapy is depending on the physician discretion.
But in the monotherapy arm, they got no antiplatelet after the procedure?
Absolutely. Is it monotherapy arm after procedure? Is it just we include in the just stabilize the patient as your trial, find your EPIC trial, another Augustus trial included the early period of the trial after PCI. Our trial just chronic stable patient after PCI at least 6 months, beyond PCI, and the acute coronary syndrome at least 12 months beyond the PCI. So even though at that period with randomization in the Edoxaban monotherapy arm, we stopped the aspirin or clopidogrel just to keep Edoxaban monotherapy, and the dual therapy group, and we are adding the Edoxaban plus single antipress therapy.
Okay. Well, congratulations on yet another great trial. And thanks for joining us today, Dr. Nam. Thank you, Dr. Park. And it's an honor having you. And thanks to all of you for joining us here live from ESC 2024.